Destination Change, a podcast where we talk recovery, treatment, and more. I'm your host, Angie Fiedler-Sutton, with the National Behavioral Health Association Providers. Today's guest is Lee Dalphonse. As an educator, organizational consultant, and psychotherapist, Lee has consistently been recognized as a tireless advocate for the underserved, with his advocacy targeting issues of access, quality, and effectiveness of mental health and addiction-related services. Recognized locally and nationally as an agent of change, Lee has consistently been at the forefront of emerging best practices and an early adopter of numerous innovations in care delivery that are now considered the gold standard of care. Lee holds his dual state licensure as mental health counselor and a chemical dependency clinical supervisor, and he is board certified nationally in mental health counseling and board certified internationally in alcohol and other drug counseling. Lee's work experience includes nearly 14 years as an adjunct instructor in the graduate counseling program at Rhode Island College. Throughout his career, Lee has also provided training and organizational consultation services to a variety of audiences, governmental entities, and human service organizations throughout the United States and Canada. Lee's leadership in the behavioral health world has been recognized via several awards and was recently the vice chair of the ICNRC Board of Directors. Thank you very much for coming, Lee.
Well, Angie, thank you for inviting me. It's a pleasure to be on this podcast today. Yes, I'm challenged by these earbuds that keep falling out.
That's okay. People who are familiar with the podcast already know what I'm going to ask, but for those who are new, I always ask kind of how you got into the recovery space, what made you choose working in that versus all the other career options that are out there.
That's a great question and a great theme that you're carrying through this podcast, which is an important voice for the field, which is it's all about change. And I think that for me, getting into recovery space, getting into this type of work really started, I think, when I was a kid. My experiences, not to give more detail necessary, but it goes back to childhood. I was in foster care for quite a number of years, and biological parents were suffering from their own mental health and alcohol, other drug-related challenges, so they weren't really able to care for their children. And as a result of that, I ended up in the foster care system along with 4 of my oldest siblings at the time. So that experience, and then I was adopted later in life, and was raised by adopted parents who did a great job of, I think, helping me to get on track, and I give them credit for their love and patience to that. But what that taught me also was that not everybody got the chance to be adopted. So instead of sort of viewing my experience as focusing on the fact that there were some aspects of it that were difficult, I focused more on the fact that I was given an opportunity. And with that opportunity, I wanted to do something. And I knew what I wanted to do early on was to work with people. Didn't know exactly what that meant, didn't have that defined as a career goal necessarily, but I knew that I wanted to somehow make a difference and sort of, in a sense, pay it forward, as they say. And so I started out working in a state hospital in Maine with patients that were severely and profoundly disabled, and moved to Rhode Island, got into early on working at a psychiatric hospital, and then outpatient substance use programs, resident substance use programs. Over the years, worked with a variety of populations in a variety of settings, but the theme throughout all of it was to do what I could to address issues of access, quality, and effectiveness of services. I saw a lot of services that were really good, and I saw a lot of services where, over the years, where they weren't really practicing the latest science. There seemed to be a significant gap between what the emerging science was teaching us and what we were doing in the field. So that sort of inspired me to put my energy and passion into bringing science to the streets, they say.
Great. In terms of, you've been in the industry for quite a while. One of the things I like asking is kind of what do you find easier than it was when you first started, or what do you find harder as well? Kind of some of the differences.
It's a great question. What's easier is that a lot of what I was agitating for 20, 25 years ago, things like integration of mental health and addictions treatment into the rubric of behavioral health, or integrating physical care in behavioral health care, are things that are widely accepted as this is how we should do business. But when I first started talking about that, I used to do a lot of trainings way back. And when I would do a training, it would either be a straight mental health treatment audience or a straight substance use treatment audience. And it didn't even have people in the same training events. And people really held on to the more traditional views of mental health or more traditional views of addictions treatment originally, the idea that I falsely believed that they were treating different populations. And it was hard to get some people initially to sort of buy into some of what you're trying to sell. Think that you got to sort of accept that as par for the course if you're trying to challenge the status quo. If you're agitating for doing things different than the way they're currently done, people do have an investment in the status quo a lot of times. So you're sort of pushing against the current at times. You know, over time, it is gratifying to see the field and the industry move together. You don't really hear people talking much more about the idea that mental health and substance use are different fields or should be treated differently. And what you hear much more people talking about having clients with co-occurring conditions. And I think that one of the biggest frustrations I've had over the years is when we design programs based on a certain idea, a certain model, and then we expect clients to fit into the program. And if we turn away a lot of people at the front door based on the idea that they don't fit, and where those people go, right? Where do they get treatment? And what we really have to do is focus on how do we fit treatment to meet the needs of the person presenting for treatment, as opposed to that the idea of the no wrong door. One of the statistics that's always bothered me over the years, it seems to be improving over time, but it had held constant for probably at least 2 decades, was the idea that in excess of 49% of individuals with co-occurring mental health and substance use disorders weren't in treatment anywhere. Those are the people that needed the interventions and the skill sets of both fields, and they were being pointed in opposite directions. A lot of times when treatment programs had this sequential mindset, take care of your mental health problem and then come back for addiction treatment, or stay sober for 30 days, then come back for mental health assessment, that kind of sequential treatment as opposed to an integrated treatment approach, was the norm for a long time. And to be fair to the programs that operated that way, a lot of times they operated that way because that's what the funding streams specified. And to some extent, the funding streams still segregate funding based on a diagnosis. So as we look at what's going on currently, I think that there's an emerging science that's really even challenging the idea of a diagnosis. More of the idea that treatment interventions need to be what they call transdiagnostic treatments. And so looking at the common underlying neurobiological processes that manifest that lead to what outwardly we call a mental health or substance use problem. But if you look at what's going on in the person, it could be, in the case of a lot of the mental health conditions that we treat and a lot of the addictions, it's really what we got: low distress tolerance, a high reactivity to stress, difficulty self-soothing and calming down once agitated, sort of hypervigilant worldview based on potentially developmental trauma exposure, and those sort of biological and developmental factors manifest in all kinds of ways. It could manifest as an anxiety disorder, it could manifest as a mood disorder, or as an addiction, or any combination thereof. But really, it's the same underlying interpersonal neurobiological sort of phenomena that's going on there. So I think the more that that gives me hope to see that science is really melding these things together. I think in a pretty profound way, with a lot of the advances in fMRI technology and neuroimaging, that really shows what actually goes on in the brain. It's led to a much better understanding of the illnesses that we treat, and I think hopefully will also shape going forward the treatments that we embrace and the way that we approach care.
Now, the opposite, what do you find harder nowadays than or more difficult to do than when you first started?
I think that because I do work in both the nonprofit world as an organizational consultant still, and in the more traditional insurance world and my own private psychotherapy practices. And I find with both of them the issue of funding, there seems to be a very high demand for services, but really frequently funding rates or insurance reimbursement rates that don't keep pace with the actual cost of providing the care a lot of times. And so constantly sort of worrying about money if you want to do the right thing. For example, to do a good comprehensive assessment in an intake, just in private practice, for example, if you do it right, it could take 2 or 3 hours to really get to know a person really well, to do a comprehensive biopsychosocial assessment, and to really assess them in terms of the level of developmental trauma exposure and addiction related risk factors and relapse risk factors and even risk factors to self and others. And then to document all that, but the average insurance company gives you 45 minutes to do all that. It's not realistic, obviously, if you're going to do it right. Conversely, when I was working in the more of the traditional, publicly funded nonprofit world, which is where I spent most of my career, as I rose up in leadership, I became more and more acutely aware of the constant struggle to get funding. So you get a grant, it's great until the grant runs out, and then you either got to displace staff or repurpose staff, and so you get these innovative programs up and running and funded, and then you didn't have the funding to keep those great programs going. So it felt like you're sort of, fixing one thing at the same time you're breaking something else. And so that, and I think that this is a trend nationally as well as in my local area, but there seems to be sort of a chronic underfunding of mental health and addiction related kinds of issues. And when they do fund it, it's sort of funding it it's like taking money out of one bucket and putting it in another. So like, with the opioid crisis, there was a lot of money put into opioid treatment, but it was really the same money. It was just taken out of things for funding for alcohol, funding for prevention, funding for other drugs, and put into opioids, with the idea that we have a single problem. But in reality, what we have is a trend that's consistent since it was 1990. All the longitudinal data shows that the rates of deaths of despair have gone up in every category, not just opioids. They've gone up in opioids, certainly, that makes front page news frequently, but we also have the rate of suicides gone up consistently. It keeps continuing to go up year after year, as does the rate of deaths from cocaine, other stimulant drugs, deaths from benzodiazepines and similar drugs, alcohol poisoning and alcohol-related deaths continue to rise. So, and as does straight suicide. So what you really have is people dying because of mental health and substance related problems at rates that have been getting worse every year since 1990. And the funding has really stagnated and gone backwards as a percentage of the total expenditures that a state may put forward or the federal government may put forward, the percentage that's allocated for mental health and substance related issues, has over time not kept pace with inflation, and you see that sort of everywhere. Like you throw money at a problem temporarily, but then you don't continue to fund it at the same rate or don't allow a system to really sustain itself. That's a concern. I remain somewhat hopeful, though. I just want to sort of not just talk all doom and gloom. I think that there is a national initiative, the Certified Community Behavioral Health Centers initiative, which moves the mental health centers, away from a per encounter, 15 minutes at a time billing model, which is frequently underfunded because the rates, again, don't keep pace and you only get paid for the person's there. And if you're doing outreach and engagement, you're not getting paid a lot of times. They're moving, the Certified Community Behavioral Health Center initiative moves to a cost-based retrospective payment system similar to what they use in the federal qualified health, consistent with what they use the federally qualified health centers, and on a cost-based model that if you give a bunch of free care away because people are uninsured, or you give more services than anticipated, you get made whole when you do your cost-based, accounting at the end of the year. So I'm hopeful that if the country continues to go down that direction and does that consistently, that there'll be sufficient funding mechanisms in place so that behavioral health organizations can succeed financially and sustain themselves. And one of the interesting things about the federally qualified cost-based programs is that they do require you to, take all eligible people, and you can't turn people away because of insurance or because of lack of money. And so, because with the idea you'll get made whole later when you do the cost-based accounting. A better model because it doesn't incentivize, only taking people that are insured or only people with certain types of insurance. It also mandates that they address as a private population clients with substance related conditions. So I think it really further consolidates and integrates mental health and addictions treatment in the public service sector, anyways, which I think is a very good move forward.
Awesome. You mentioned deaths of despair. Your doctoral dissertation was an investigative study of the association between state level health and economic indicators and deaths of despair. Talk a little bit about that and kind of what made you decide to focus on that area.
Well, thank you for asking. The death of despair actually is a term that comes out of work economists Agnes and Deaton. They coined the term death of despair, and they were talking about the idea that it was a state of despair that was leading to these deaths, all these deaths that were going on that I just talked about. Deaths from suicide, deaths from alcohol and opioids and other drugs. And they were saying the despair, and they looked at the economic conditions that contribute to the despair. And so when I looked at my study, I wanted to sort of do two things. I wanted to sort of, test out the hypotheses that they put in their book. And they put out a book called Deaths of Despair. And it was really just a sort of a summary of all their longitudinal studies they'd been doing. And so I wanted to sort of test out their model with more updated data. So at the time I had 3 years worth of data from 2017, 2018, 2019. And I had 15 measures looking at state level health and economic indicators. What I wanted to do was sort of test out the idea of, what are those factors that contribute to that state of despair? And also, I wanted to make the point that I think I sort of alluded to earlier is that I think this country's been falsely talking about an opioid crisis when we really have we have a behavioral health crisis. Yes, I'm not trying to de-emphasize the importance of the focus on opioids, but I don't want that emphasis to get us to sort of, not look equally seriously at how many people are dying from suicide, how many people are dying because of alcohol-related deaths, benzodiazepines, psychostimulants. And also, if you look at the death data, you also find that they may put a single cause of death down, like opioids. But what was very common, if you looked at the multiple cause death data for the different states, what you had is a sizable percentage, if not the outright majority, of individuals that may be labeled as having a death related to opioids also had benzodiazepines or stimulants or some other drug in the system or alcohol in the system. And even with the opioid deaths, some were absolutely unintentional overdoses, but some were intentional suicides too, because you also have people. And so then what I found in my study was that the one of the biggest issues was unemployment. Not having a job that was sufficient to support your family. It seemed to be a very large indicator. That sense of purpose, that sense of, I can, take care of myself and my loved ones in the world and survive. And when people lost the ability to do that, the economic despair. Also, the education. There seems to be a connection between, and maybe that's also sort of tied to career opportunities too. With education. But education has become so unaffordable for many people that it becomes a barrier to opportunity. Also, the presence of co-occurring conditions was also a significant factor. It goes back to what we talked about earlier, that, people don't typically just have a mental health problem or just have a substance-related problem. Frequently, you see them coexisting, And when there were co-occurring conditions, especially if there was barriers to access or there wasn't access to effective interventions, then the rates of death were much higher in the states. For example, states that really made it difficult to access methadone treatment for opioid addiction had much higher rates of deaths from opioids, as you might expect, right? And states that were more innovative, and the states that, introduced access to medication assisted treatment, early on in some of these opioid use history and had better rates of survival. So again, I think it's an idea that deaths of despair really is something that, as a society, if we take it seriously and we put the right resources into it and we take a science-based approach to it, we can have much better outcomes. But if what we have is a headline-driven sort of political response that sort of, take money from here and put it over there to patch up the problem, then we continue to have more of the same.
Exactly. One of the things we talk about is kind of the barriers of recovery, and money is definitely a big issue there. Let's talk a little bit about your work experience as an adjunct instructor at Rhode Island College.
I taught there for 14 years. I actually stopped teaching there when I went back for my own doctorate. 'Cause I was teaching as somebody with a certificate of advanced graduate studies, and as a licensed professional, I was teaching there as an adjunct instructor. However, when I went back for my own doctorate, I went back later in life. I actually completed my doctorate 2 years ago, so I was like 63 at the time. So I wasn't really able to work full time and teach and work on my doctorate. But when I was teaching a few different courses. As an adjunct instructor, you usually get the courses that the regular full time faculty don't sign up for. So you don't always necessarily know. But I was fortunate enough to have been there long enough time that I did get to teach a lot of the same courses. I taught the ethics class frequently, bringing ethical practices to the mental health counseling. And I regularly taught the assessment course, which is we teach people how to diagnose the use of the DSM and the ICD, and understanding the diagnostic formulation and differential diagnostic process. And I taught, there were two classes related to substance users. They started out originally as straight addiction types of classes, but I was able to work with the chair of the department and faculty of the department to get it so that the requirements for those courses and the learning objectives were tailored towards co-occurring treatment, so that people that were interested in pursuing ICNRC's co-occurring credential, or that wanted to, develop an expertise in co-occurring treatment, taking these two courses, gave them, total of, 90 credit hours towards that, 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 that type of specialized training. And I also taught from time to time the clinical practicum classes and the internships when people actually, post graduation, or right near the end of graduation rather, as they, finished up their academic studies and they're getting ready to do their post graduation pre license work.
Now, I know you've done a webinar for us, which I'll link in the show notes. With other webinars, do you typically stay to the same topic, or does it just kind of you vary depending on what you are interested in at the time?
Actually, I sort of, when I talked earlier about the idea of bringing science to the street, I think there are a lot of reasons I like to do, whether it's, teaching at Rhode Island College, or the various seminars and workshops and conferences that I've spoken at, that there's always been consistently a theme of sort of trying to figure out what's the new cutting edge sort of science that's coming out there. And sort of by doing training, sometimes I was learning some of the stuff myself. It sort of forced me to stay current in the literature and to stay current in the research and to integrate what I knew with what seems to be coming out, and sort of, challenge my own thinking as much as sort of putting ideas forth. So my trainings have evolved over the years to sort of coincide with whatever is sort of seeming to emerge as the latest and greatest, if as it were. Like for example, most recently, the training I've been doing is around interpersonal neurobiology, and some of the latest findings in neuroscience and the implications of neuroscience on even our understanding of something like developmental trauma and attachment disorders, and what's the relationship of all of those things to the risk for addiction. And so when I first started doing it, it was really teaching sort of mental health 101 to people in the substance use world, or teaching substance use 101 to people in the mental health field. But I think there's been an evolution of thinking throughout the field in both mental health and addictions. I think regularly I see that people are much more adept and knowledgeable about, you know, uh, the innovations in the field, and think more holistically and more integrated than I think when I first started in the field. So it's really comforting to sort of see the growth in the industry.
Great. You mentioned briefly in your prior answer IC and RC. Let's talk a little bit about your work there. How did you get involved with them? How did you get to be vice chair?
Okay, sure. I have been involved in the credentialing, licensing, and certification processes at the state level since I don't know exactly yet, but it's been in excess of 20 something years that I've been involved with the Rhode Island Certification Board, which is the nonprofit board that issues the certifications for substance abuse professionals and treatment and prevention professionals. And for the last several years, I've been the chair of that board. And I've been one of every year our board, the Rhode Island board, sends two people to ICRC. They typically send a treatment person and a prevention person. And for the past, I don't know again the exact years, but 15 plus years, I've been involved. I've been going to the ICRC meetings, as a representative initially of the Rhode Island board, as the treatment representative. And in as is my tendency to sort of, I'm going to do something, I throw all in and get actively involved. So I was going to the semi-annual ICRC meetings as a board representative. It made sense to me to get actively involved in ICRC, so I did. And over the years, I've served in a variety of capacities in there, including at one point as the co-chair of the co-occurring task force, and then the co-occurring credential committee when ICRC came out with the co-occurring credential. And even though I was the co-chair of that initiative, I was also a year or two later led the charge, if you will, to try to get ICRC to rethink having a specialty co-occurring credential because that implied that only some people needed to know about co-occurring treatment. And I have a firm belief that to be a competent addiction professional, you have to understand mental health, and to be a competent mental health professional, you have to understand addiction. So what we, instead of having advocating for the continuation of a standalone co-occurring credential, you know, uh, so advocating, and it was eventually adopted by ICSC, was the idea that co-occurring principles and competencies need to be infused into the treatment credential itself. So in other words, in order to get an ICRC credential, you'd have to become co-occurring competent. And that, I think, makes more sense in the long run because it says that it ups the expertise of the whole field as opposed to just a few people that choose to, have that specialty or expertise, if you will. Then, I guess because I've been around for a while, then I ended up on the board of directors and then voted in as vice chair. I served that capacity, I think, for about 2 years, and I stepped down last year because my term in Rhode Island, we have term limits for the certification board. And I'm term limited as of this coming June. So in a few months, I'll be off the board after 20 plus years of being on it. I also currently serve on the state licensing board. Because in Rhode Island, we have, for addictions, we have a licensing board and a certification board. Now, there is synergy between the two because under the Rhode Island regulations, in order to get licensed as an addiction professional, you have to obtain and maintain the ICRC equivalent credential, which goes through the Rhode Island Certification Board. So you get the certification through the Rhode Island Board, and then you apply for the state license. So I was appointed by the governor to the licensing board. This is the second time I've been on that board. I was way back when that board. I was involved when Rhode Island first adopted a license. I was involved in helping craft the legislation, and then so I served on the original licensing board as the chair at one point. Then I stepped away from it and focused on the certification board. And I was also at one point the chair of the Rhode Island Mental Health Council Association. Again, I had my foot in both waters, if you will, both in mental health and uh, addictions treatment, because originally there were separate fields and, like I said, separate workshops, separate council organizations. I'm seeing more and more of that integrated, but it all started out sort of very separately.
Awesome. Well, as your bio mentioned, you're the forefront of emerging best practices and an early adopter of numerous innovations in care. If someone wanted to get more information in terms of these, emerging best practices, what kind of resources would you give them?
Well, it depends on like what about. For example, with the doing some organizational consulting currently with two distinct types of organizations. Two of the organizations I work with serve homeless veterans. And so the resources for around, addressing the mental health and substance related needs of homeless veterans would be very different than other populations that I'm consulting with. I'm doing work with another organization that specializes in serving individuals with intellectual and developmental disabilities who have co-occurring mental health problems. So that's a whole different sort of area of expertise or area of resources. So I think that what I would probably, depending on like what somebody was concerned about, I'd probably try to point them out to what's the literature base. I'd start there, so it's not just my opinion. What's the research show as effective or emerging best practices for this population? Again, I think you're going to find out that emerging models are not so diagnosis specific as we've designed our entire system historically around a single diagnosis. But what we're finding is, the people with the most complex needs, people that really need the most innovative services, don't have just one diagnosis. The clients I'm working with that have intellectual and developmental disabilities and mental health problems frequently have pretty substantial trauma histories. Having a disability and being different than somebody, led them to be, stigmatized in school settings and ridiculed by peers and sort of feeling, they don't quite fit in a lot of times. And so, they grow up with these traumas and not frequently, but certainly pretty sizable percentage end up with substance related problems too. It's a way to fit into a peer group, so it feels like, geez, this group accepts me, right? Until it becomes a problem because now they have to stay on substance use. So again, I think that start with, to go back to your original question of, what would I point people to? I'd certainly start with the literature base, what does the research show? And then ideally identify, are there innovative programs or resources locally? Sometimes there are, sometimes they're not, when you're working at sort of in the idea of doing sort of innovative, out of the box things, or even emerging best practices, sometimes means it's not a evidence based practice yet, right? It's an innovative new idea that's coming out. It looks promising, but you don't necessarily have this body of evidence that says, yeah, this is definitely the approach. So it always takes early adopters. So I think a lot of it's about sort of appealing to people's passion they call it the iron triangle of healthcare, right? Cost, quality, and access. And engaging people in the conversation of, if we're going to put resources and time and money into this, how can we, remove barriers to access and produce the best outcomes? So it's really that kind of conversation, and I think that's better than, because otherwise people can hear when you talk about change. And I learned this early on. I think I used to be sort of maybe perceived as an angry advocate. I would think that what I was pushing for was right, and sometimes would probably come across in a way that might turn people off because they would see it as I was saying what they were doing wasn't good or was wrong. And so you have to sort of use motivational enhancement strategies. Change it, just apply change theory to my peers, right? You have to sort of approach it from a way of, gee, as Marshall Linehan says in DBT, you're perfect the way you are. Let me help you change everything. And I think that's what we got to sort of say in the field too. It's like, yeah, we've done a great job, but we can do better. And what's that mean? It means like looking at, and one of the ways you look at it is, who are we not serving? In Rhode Island, the CCBHC initiative has really become an opportunity for the state system to not just, talk about how they can improve care for the people already serving, but how can we address the needs of the populations that we've completely missed? Because they're out there, and the ones that are out there are frequently the people that have multiple co-occurring conditions, and so the system sort of points in different directions for them, and we need to sort of have a no wrong door approach. I think that you're going to get a comprehensive assessment, and the needs will be met regardless of what we call it.
Great. Our audience is a wide range. We've got everybody from, individual counselors to CEOs. So rather than asking for advice to them, what I typically ask is, if you could go back in time to when you were first starting, what would be some of the advice you'd give yourself?
Well, two. One I alluded to already, which was, don't be the angry advocate, because that's not very effective. It doesn't really that I want to be a change champion or a change agent. I want to, and I talk about effectiveness. Well, I would be effective as a change agent, right? If I'm just rallying against the machine and complaining about how everything's broken, but I don't, inspire people towards a different solution, then I'm not really very helpful myself. I'm just another loud voice in the crowd that's complaining about how bad things are, right? So I had to sort of learn to become more positive in my approach to things, and sort of, and also I had to sort of, recognize the need for patience, right? That, like if I look back now and I think, gee, 30 plus years later, that how far we've come, but I wasn't always aware of that, because of the lack of patience on my end. It's like it wasn't happening fast enough to change. It's like, I told you about this last year. Why isn't it fixed? And so that I had to really come to terms with the idea that, that people are open to change, but nobody wants to be changed, right? I think that's true of institutions too. The institutions, are open to being malleable and adjusting and changing, but they don't really want somebody to come in and blow up the ship either. And so you've got to really be able to, you know, I guess use transformational leadership and inspirational leadership, and that comes from sort of a strengths-based approach. And you also take into account, like, there's some good reasons that people hang on to the status quo. In terms of, if you really, so you've got somebody who's developed a program, they're proud of it, and they've worked hard at it, and they think they're doing a great job, and so they're not going to necessarily be initially too open to, well, why would I fix this? It works good, right? So you got to sort of show them. And I guess the theme really that I think became more saleable to people is the idea of, yes, you're doing a great job with the people you have, but what about the people you don't have? The people that don't make it through the front door, and how can we develop innovative services for them? So then they started, I think people are less defensive then. So okay, so there's this other population out here, but you're not saying that what we're doing now is wrong.
Now, we're getting close to the end. Was there something that you wanted to talk about that we haven't, or something that you thought I was going to ask, but I didn't?
No, I think you've asked some really probing questions, and I appreciate that. I think that we sort of jumped around to different topics, but I think that what I would encourage, I guess, sort of as a closing thought, if you will, is the idea that is to recognize that just like we know with our clients, change is a process, right? And institutional and organizational change is a process too, right? And so, if we approach it methodically, though, sort of say, okay, so how do we help clients change, right? Well, if you take a strengths-based approach and you use motivational enhancement strategies, with clients, that same kind of approach can, I think, inspire organizations to change and to grow. And I think no matter what your role is in an organization, I think anybody can be an agent of change. And I think that's hopefully, if nothing else, you sort of recall from anything that I talked about today. It's that idea that change happens, one person at a time, right? So wherever you are, if you could bring a new idea to your agency, or bring a new service, or get the agency to open up to the idea of offering, easier access to a population that's historically been leveraged out of the system. And anything you do, not only do you make a difference for the clients that you serve now, but you may lead to a permanent change in the agency that makes those new services, those new innovations available to future generations of clients too. And so your impact, I think, in the field can be much more profound if you are always looking at it of that continuous quality improvement idea of, yeah, our system's good, but how can we continue to make it better?
That is a great way to end. If someone wanted to get in contact with you or wanted to learn more about you, how would they go about that?
You could reach me at leadalphonse@gmail.com. It's a nice, easy email address, just my name at gmail.com. My private practice is at Sheehan Psychotherapy Associates in Warwick, Rhode Island. And the website, I think, is sheehansite.com. That's SHEEHAN site.com.
Awesome. You've been listening to Destination Change. Our guest today was Lee Dalphonse. Thank you for being here. Our theme song was Sun Nation by Kitsa and used via Creative Commons license by the Free Music Archive. Please consider rating and reviewing the podcast on Apple Podcasts so we can get more listeners. In the meantime, you can always see more about the podcast, including show notes and where else to listen, on our website, www.nbhap.org. If you have questions for the podcast, please email us at info@nbhap.org. Thanks for listening.